Hello everyone, I am Nishad Gewali from St. Vincent Hospital. I would like to thank you for reviewing my poster. Today I would like to discuss a case of adrenal insufficiency secondary to inhaled corticosteroids. Suppression of hypothalamic pituitary axis by exogenous glucocorticoid is the common cause of central adrenal insufficiency. However, this is less common with inhaled corticosteroids. The clinical manifestations are non-specific like fatigue, weight loss, nausea, abdominal pain, and myalgia, and hence high index of suspicion allows timely diagnosis of potentially life-threatening disorder. This case is about a 51-year-old Asian Indian woman with type 2 diabetes mellitus, hypertension, hyperlipidemia, bronchial asthma, and a remote history of treated tuberculosis. She presented with complaint of fatigue, fever, cough, decreased appetite for a few days. She was taking metformin, irbesartan, and atorvastatin. In addition to this, she was using inhaled fluticasone propionate 220 microgram per puff 4 times daily with a total dose of 1760 microgram per day for bronchial asthma. She had cut down on her dose of fluticasone for past few days because of better control of her asthma symptoms. At presentation, she was noted to be hypotensive with blood pressure of 78 over 36, heart rate of 110, and temperature of 98 degree Fahrenheit. She was lethargic but oriented to time, place, and person. At presentation, physical exam showed sparse axillary hair, and rest of the exam was unremarkable. Initial lab work showed hemoglobin of 11 gram per deciliter, WBC count of 6,900 with 10% of eosinophils. Sodium was 135, potassium 2.8, and phosphorus of 1.1. CT chest showed right lower lobe focal density suggestive of pneumonia. Given the overall presentation of gastrointestinal symptoms, hypotension, loss of axillary hair, eosinophilia, and of course, history of tuberculosis, suspicion of adrenal insufficiency, likely primary adrenal insufficiency was high. ACTS stimulation test was done, which showed subnormal cortisol response, but surprisingly, serum ACTS level was very low. Adrenal and pituitary imaging showed normal findings. Based on clinical features and biochemical finding of low ACTH and low serum cortisol, the diagnosis of central adrenal insufficiency was made, most likely due to HPA suppression from chronic high-dose inhaled corticosteroid. The patient showed remarkable clinical improvement following the administration of hydrocortisone. She was treated empirically with doxycycline for pneumonia. She was later weaned off hydrocortisone over next few months. This case illustrates the acute presentation of chronic central adrenal insufficiency due to inhaled corticosteroids, which was likely precipitated by the stress of pneumonia. Inhaled corticosteroids are absorbed in systemic circulation. There are several reports of growth stunting in children on high-dose inhaled corticosteroid for asthma. In a study by Sim et al. Published in European Respiratory Journal in 2003, 12% of patients on high-dose inhaled corticosteroid showed a subnormal cortisol response to ACTS stimulation. These patients had no manifestation of adrenal insufficiency, which could be attributed to partial suppression of HPA axis. Patients with partial adrenal insufficiency can develop adrenal crisis when subjected to stress, as seen in our case. Timely diagnosis and treatment can be life-saving. Thank you, everyone.